said about silica or livestock-related activities are only associations. This is based on interviews, and there is not cause of proof and no cause-effect relation. What kind of diet shall I follow? That's another question. We have no data, but maybe food allergy it could be associated with Church-Strauss disease. We don't know this, but it's an interesting question. We need to maintain, I'll tell you, to maintain a healthy and balanced diet, which is good indeed for general health. How my emotional, psychological status affect me? We have no data. For example, we know from patients with lupus that sometimes a flare can occur if they have a problem, and that is why I will ask you to get help and support and speak out if you feel you're under stress. I mean, even healthy people do not feel well if we're stressed, so now this is very important to speak it out with your doctor. What about alternative medicine? This is a very delicate matter. I would say to get caution, to be cautious, to get advice. And there is one report based only on one patient who used traditional medicine in Church-Strauss syndrome for his skin lesions. And I would say that if you're going to try this, please ask and stick anyway to what is based on evidence on large number of diseases, and it's proven to be useful in your disease. Finally, is there a cure? No, but definitively there's a better control. We have come out much more further in studying and treating these problems, and I want to underline that these diseases are not contagious and not hereditary. There are many factors that influence how these diseases behave, some from patients, some of the disease itself. I won't go through this because of time, but I want to mention that we are getting closer to know finally what is going to happen in terms of coming with new therapies and coming with new evidence of what causes this disease. As closing remarks, I want to say these are rare diseases, but we're getting more interested in them, and we're getting more interested also from other organizations, that many of the advances have been made through interdisciplinary work. This has led to better outcomes and longer survival. We have more of these problems diagnosed very early because of improvement in imaging and lab tests. We now better we use better and more judiciously the treatments available. We're getting into an era of drug development which is very promising and is growing fast. We have gone into offering better life quality, and we need much better assessment. And in fact, getting your opinions about this, the outcome will be much better obtained if we know what you feel, and this is a very important input to what we need to know. Finally, organizations like this stimulate us and induces us to get more research and help us to get to know the etiology, which can finally lead to prevention and education, and we then could tear down the wall that I just mentioned before in one of the slides. I want to thank you very much for your attention.
Cornelia Weyland, or Connie Weyland, is known to us, needs no introduction in the rheumatologic and vasculitis world, but I will introduce her to you because she's new to the foundation in terms of coming to speak at this meeting, but not new to vasculitis research. Connie is one of the world's leading basic and translational investigators in rheumatology. Her work with her laboratory, with her partner, Jörg Garanzi, has been fundamental differences and changes in how we think about rheumatoid arthritis, inflammation, and giant cell arteritis, and other forms of vasculitis. Her insights into the pathophysiology have been extremely important in advancing the field, and she also sees patients and has been running vasculitis programs for some time. She fairly recently moved to Stanford University. We're happy to have her. They're happy to have her as a professor of medicine, and I think it's a pleasure. And she's relatively local in terms of California, and I wanted to welcome her and come on up and talk about large vessel vasculitis.
So who is from California? Bravo. You see, there's something very special about California, right? This is the new America. We got to, you know, schlep them behind us. So let's keep moving. You know, Stanford has been a place that has made its mark on the map. Stanford has moved the understanding of disease in quite a fantastic way. You know that they literally brought about heart transplantation. They have a long, long tradition in blood vessels, heart disease. So vasculitis is an absolute fit into the Stanford community. Now, what Stanford also does, it is not hampered by tradition and how we have done things. We have just moved to restructuring the way we look at medicine. Stanford has moved ahead and has created what we now call the Institutes of Medicine. So we have really left behind the old structure that if you have something wrong with your thyroid, you go to the endocrinologist because that's where it is on the map. We want patients to go and see doctors that are interacting with other doctors that's relevant to their disease. And accordingly, we have, of course, then structured the vasculitis clinic that it brings together not only rheumatology, but the neurosciences, and we have an Institute of Neurosciences. Of course, the cardiovascular medicine program. We need the eye center. As you know, the eye center is very critically involved. And of course, we need the vascular surgeons. And what would we be if we wouldn't have a way of looking at blood vessels in a new and cutting-edge fashion? And that's where the imaging center comes in. And you know, Stanford invented the MRI. And the push right now is to go and create imaging techniques that allow us to put you in a machine and then tell you whether you have inflammation in a blood vessel or not. So when Peter asked me to talk to you about 4 different diseases, I said that's not of much use for them. We will talk about one and its cousin, and if you fall into other categories, you come to me and I will personally talk to you about them. So giant cell arteritis, the disease we will focus on, it's also known as temporal arteritis or cranial arteritis, and it has a cousin, polymyalgia rheumatica. And for all what I'm going to say about giant cell arteritis, polymyalgia rheumatica falls into the same category. It's just that the disease process is not as aggressive and destructive as that in giant cell arteritis. So why do we call it giant cell arteritis? Because when we go into the tissue of the patients, we see these giant cells. So this is one big cell. I put a circle around it. Where is my arrow? There it is. Can you believe it? This is one cell, and all of these nuclei came from different cells together, and the cells were fusing, and now that cell has about 30 nuclei. And because it's a very unique shape of a cell, the pathologist can see it easily, and they call these giant cells. And when giant cells they're found in a tissue, that means something. Now, many of my patients say to me, they didn't find giant cells in me, I can't have giant cell arteritis. That's not correct. About 50% of the patients, we will not see these creatures. But in 50% we will, and that gave the name to this disease. So I thought that I'll share with you what we know about this disease, and we will focus on the major question. Who gets giant cell arteritis? The typical patient is older than 50 years of age when they are diagnosed with giant cell arteritis. This age cutoff is so absolute that actually there's no convincing cases of this diagnosis in individuals that are younger, with the exception of Takayasu's disease, which is very similar, has many overlaps. It's not the identical disease. And you know that that occurs in individuals that are much younger, and they are usually younger than 40. And, but what the giant cell arteritis patients and the Takayasu share is that more often the patient is a female than a male. It's about a 3-to-1 distribution. Many of our patients, we have just looked at our collected data, get sick. They get sick out of the blue, meaning they are rather healthy, and this falls into their life as an unexpected and intense deviation to their path. Now, the typical patient complains about, as I say here, headaches, tenderness of the temples, soreness and stiffness of the muscles, mostly in the shoulders and in the hips. I can't find my arrow. Is this actually? No, this is not a laser pointer. Okay, we'll muddle along. Patients come and have fever. They have weight loss, night sweats, and malaise, and we call that failure to thrive because it's all coming together, and these people don't do well. They get sick. They go and see a doctor, and usually they have a history of seeing doctors till they end up seeing us. Now, most significantly, some patients lose vision, and that is a big determinant, a strong determinant in how we diagnose, handle this disease, and how we handle decision-making processes when we make the diagnosis. The less typical patients have pain in their arms when they use them, rarely in their legs, or what's happening more and more now to us, they are diagnosed with an aortic aneurysm or a dissection, and actually the vascular surgeons are coming to us and saying, the pathologist says there are giant cells in this specimen. What should we do? So how is the diagnosis made? How can somebody actually claim you have giant cell arteritis? The golden standard of making that diagnosis remains biopsy of the arteries of the temples. One can do that on one side or on two sides, and we can discuss that. The tissue sample then shows inflammation, and as I told you,